So it's somewhat inspiring to be following 3 talks about scaling out treatment of prevention in China, Malawi, and Swaziland. I'm going to switch topics on you here, though, and start to look at the US, a country which has not particularly had a big scale-up effort in treatment over the last years. But nonetheless, most countries that have already been treating people have this ongoing challenge of assessing how things are actually going in the country, and that's a little bit what I'm going to be talking to you about today within the context of the HPTN 065 study data systems. So this is the cascade as it was assessed in 2011 of what's going on in the US with engagement of HIV care and treatment. And today I'm really going to be focusing on the piece of the cascade amongst those people in care, the degree to which we're achieving viral suppression amongst people who are regularly seeing providers. I think the actual gold standard data for this assessment truly should come from the Medical Monitoring Project. This was reported at CROI. This is a project that is run by the CDC where they do this formal multi-stage sampling method where they're sampling regions within the US and then care facilities in those regions, and then they go and actually do chart abstraction from HIV-infected people in care. So the first reporting from this, as I said, was done at CROI. And in this, they say amongst the population in care, which I actually don't have a clear definition of what they meant by in care, but amongst the population in care, they were reporting 89% of those people were actually on ART, and viral load suppression amongst that entire population in care perhaps being as high as 72% or as low as 72%. I think people would differ on the definition of that. But this, I think, is the gold standard. The gold standard in terms of assessment of viral load suppression amongst people in care. And what I'm going to show you today is a different methodology that we're using within the context of the TLC-Plus study that's going on in the US. This study actually has 5 components looking at studying the feasibility of the test linked to care and viral load suppression. And I'm going to be talking about one component of that study, which is actually looking at the viral load suppression. What we're using in 2 cities, in the Bronx, so in 2 areas in the States, in the Bronx, New York, and in Washington, D.C., we're doing a randomized study looking at financial incentives for patients in care achieving viral load suppression. Alongside of that, we have 4 comparison city jurisdictions in Chicago, Houston, Miami, and Philadelphia. Those cities were chosen because they had a high burden of HIV for the US. They also are cities that have been assigned additional resources for the surveillance systems from the CDC. And we have put in place resources in each of those city jurisdictions to assist in getting data that's valid and that's up to date to allow us to do this comparison. So within this viral load suppression component, what I wanted to show you, the objectives of my talk today, was to first show you how we're using this lab-based surveillance data from these 6 jurisdictions to assess viral load suppression on a citywide basis. One shortcoming of the surveillance systems is that it doesn't actually capture ART information. Therefore, we're really looking at the proportion of the population in care who are getting viral load assessments irrespective of their CD4 count and their ART use. So it's within the population in care doing that assessment. I will be able to show you an assessment of the change in population in care over time, and also give you a sort of a brief glimpse of how I'm trying to assess the data reliability. But I have to say, my assessment of this group here is there are a number of people here who are very much involved in data systems. And one of the things I wanted to show you here was for the US, how the surveillance data systems that are in place are actually have great potential for monitoring what's going on for people in care. So to that end, I'm going to tell you a little bit about where the data for my presentation comes from here. It comes from what's called EHARS, or the CDC Surveillance Data System, which is an implementation that uses the HIV/AIDS name-based case surveillance that is now available throughout all of the states in the US. It's a partnership between the CDC and local Department of Health jurisdictions. And it's an electronic data system surveillance, which receives substantial financial support from the CDC. And the TLC-Plus study is utilizing this existing system to monitor facility-level intervention. So let me give you some glimpse of how this happens. So in the US, every state, and sometimes cities within states, are a jurisdiction for the CDC's health departments. And for the way this is fairly new learning for me, but each of the 6 cities involved in HIV, almost all of them are actually a city jurisdiction that lies within a state. And when we're assessing the care that's going on in a city, some of the people who are accessing care in the city are actually living in the surrounding state. So if you take Washington, D.C., there would be people in Virginia who are actually accessing care within facilities within D.C. So when we assess, what we're doing in HPTN 065 is assessing people who are accessing care within the city. So this is therefore centered on people who are receiving HIV care assessments for HIV within facilities in the city, irrespective of where they live. And the way the surveillance systems work is that all of these facilities are having their labs done either at hospitals or at commercial labs. So all of the labs from all of these facilities are requisitioned and sent to the labs. And by law, these electronic labs are then transmitted to the EHAS systems at each of the departments of health, whether they be city departments of health or state departments of health, and there is interchange of information between the state and the city. The lab results arrive with additional information. As I said, it's a name-based surveillance system, so it has the names of the people who are HIV cases, it has the ordering provider, and it has the city of residence of the HIV surveillance cases. And so what happens in the departments of health is that these laboratory results are matched to known cases. So how does this happen? Every diagnosed HIV case is reported by name to the Department of Health, and it's assigned, these cases are assigned by residents at diagnosis to a Department of Health as an active case. And there is good funding in each of the places, each of the 6 cities that we're using for active case worker follow-up with these diagnosing physicians. So people actually go out and make sure the data is complete for each of these new cases. So when it comes to linking these laboratories that come in electronically to the departments of health, you know, the departments of health have developed these programs for doing this matching. But in addition to that, so the matching is done by name and a soundex involving the date of birth. And the HIV surveillance cases at the departments of health, again, have active caseworkers that take the unmatched cases, go back to the providers, fill in the missing data, and make these matches happen. Because of the fact that we had the facility or the provider of the lab requisition and also the city of residence of these people, this is the basis by which we have defined our cases in care and followed their viral load suppression over time. There are, however, known potential data issues, mostly to do with timing, to do with lag. One is that when people move cities, it takes a while before the surveillance systems catch up because it's pretty passive. They really have to go and they have to move cities and then have a viral load suppression done in a new city before we find out that they've moved. The laboratory results, as I said, are matched by name, and there is clearly some level of error in that. It takes a while for those issues to be phased out. In addition, some departments have a fair number of their lab tests that are actually paper-based. This is changing over time, and I'd say for each of the 6 cities that I'm working with here, there is one that I'm not reporting on, which is Miami, and it's largely because their paper-based labs have not yet been filled in for the year 2010. So now I'm moving on to what I am using as a definition of in care for HPTN 065. And it's important that you understand this because it may be different from what was used in the medical monitoring project. So if the fact that someone is in care both has a location component and a time component. So I am looking at, amongst known cases in EHAS, for people to be in care in a given city for a given quarter, they have to be accessing care at a city facility, and they had to have had, this is our definition of care, that they had 2 viral loads or CD4 count assessments within the city in the last 6 months. So if I was assessing in Q1 of 2010, here are 3 cases. Got it. So this is the quarter I'm assessing in. And what I want to do is I look back over the 15-month period, including this quarter, and if there are 2 assessments that have happened, which means that I have labs on them, this person would be considered to be in care. This person only has 1 assessment, so I'm not counting them as in care. And this person has clearly an assessment every 6 months, so they would also be counted as in care for that quarter. When it comes to assessing viral load suppression, again, it's only assessed amongst those people that are in care. If a person, so this is the definition that I'm using, if a person has been assessed, but their last assessment wasn't in either of the last 2 quarters, I'm going to say that there's no evidence of viral load suppression. If they have been assessed in the last 6 months, I basically take their most recent viral load suppression, and if it's above 400, I'm saying they're not viral load suppressed, and if it was undetectable or below 400, I would call them virally suppressed. And that's the definition I've used of in care and viral load suppressed. So first thing I want to show you is the number of people in care in each of these 5 jurisdictions. And as you can see, there are, for most cities, it remains pretty stable over each quarter, because that definition that I used in care, basically it slides every quarter. So we were looking at the number of people in care. It stays pretty stable, with the exception of Houston and DC, where there's a slight incline over time. I actually believe this one in Houston may be a result of the data rather than actually what's going on. Houston has had an increase in the number of sites doing electronic reporting, so I think the reporting may be getting more complete over time in Houston. But I won't go further. This is the second thing I wanted to show you, is when I'm doing the sliding definition of Q1, Q2, and looking back 15 months, the degree to which the same people are being in the assessment in each time. And this is, I think, surprisingly high. So in the Bronx, it's essentially 97% of the same people in care as we go along each quarter. These numbers are relatively high, that it's more or less the same cohort that's being assessed every quarter. When it comes to actually assessing viral load suppression, the first thing I want to show you is, well, let me define what I'm doing here. Is I have done this at every quarter. Here I'm just actually summing all the quarters that were assessed over the year 2010. So these are the percentage of people that had a viral load assessment in the last 6 months. So under my definition of viral load suppression, these are the people that were eligible to be evaluated for viral load suppression. So there are 15 to 30% of the people who did not get a viral load assessment for 6 months in these populations in care. So I'm counting those as potentially not being virally suppressed. Nonetheless, if I actually look at the people who had viral loads done in the last 6 months, this is the degree to which we are seeing viral load suppression. So couple of context things. This was 2010, so there was not, under the CDC guidance in 2010, there was not an expectation that everybody would be on treatment. I think the guidelines at that point were people who had CD4 counts below 500 to be on treatment. But nonetheless, in the US in 2010, we were seeing viral load suppression rates around 2/3 of the people in care. So again, you have to think, these are people who are seeing the doctor regularly, and 2/3, I don't know whether they're on ART or not, but 2/3 of that population had viral load suppression. If I now change the denominator, essentially, and include these 15% that did not have a viral load suppression, we get numbers which are closer to 60% of people, of the whole population of care, who had known viral load suppressions, who were both assessed and suppressed. I have talked to Philadelphia a bunch about this 40% number because they really seem out of line with everybody else. Again, there's a possibility that this is a data-based issue because Philadelphia did not have mandatory reporting of all viral loads, only unsuppressed viral loads, and it may be a result of the data rather than what's truly going on in Philadelphia. Just a quick look at data quality. Here, what I'm looking at here, this is sort of something that's very familiar to statisticians or people who do surveillance work. But essentially what I'm doing is I'm now looking at data for the 4 quarters of 2010. And I've looked at it once in the data that was available to us through 2011, and then 3 months later, the same period, but done at a later time to sort of see how much lag there is in the data. And I could say a year out from the assessment period, we're currently seeing what I would consider to be a very low proportion of changes in the data for an additional 3 months of work from the surveillance departments relative to the volume of quarters we're assessing. This number here, I think, again, was to do with one hospital in Houston that suddenly changed to electronic reporting, so I think there was a sort of a catch-up in Houston. But it reveals some of the underlying problems of these, underlying issues in the surveillance department. I have to say, I don't work at the departments, at the CDC or the departments of health, and I have been incredibly impressed with the energy and dedication of those people who work in the departments of health for keeping these surveillance systems up to date and really working the problems as they do. So in summary, amongst patients in care in these 5 cities with a large HIV-infected population in the US, 70 to 85% of these patients are getting regular assessment, and with these assessments, somewhere between 60 and 80% are virally suppressed. When you look at both assessed and virally suppressed, we're getting numbers which are closer to 60%. There is a very high consistency of this in-care population. Once people are seeing doctors, they seem to continue to see them about every 6 months. And in my opinion, these surveillance systems are increasingly able to support the monitoring of progress in linkage to treatment and viral load suppression within the US. Thank you.